Good morning, everyone. I want to thank all the organizers for inviting me to give a talk on innovations in management of tricuspid valve disease on our third global cardiovascular forum. I'm Dr. Srikanth Koneru. I'm the director of the Structural Heart Imaging and Valve Clinic, and I'm the associate professor of Baylor College of Medicine. I want to talk a little bit about the innovations of the tricuspid valve. Let's talk a little bit about the valve anatomy as such. You can see you have a larger tricuspid valve anterior, and a larger septal, and a little posterior valve here. And it's more of an elliptical shape when you see in a normal structure, and you have a tendon nodo and the conduction systems up there, and the coronary sinus. That's the right atrium there. And when you look at the echocardiogram with the current technology and the advances of the echocardiogram, you can actually see the tricuspid valve very clearly. And deploying a 3D, you can see the anterior mitral valve, septal valve, and the posterior valve very clearly with the pacemaker right in the middle. We know that most of the tricuspid valve leaflets are not tricuspid anymore, in the sense like almost only 50% of the patients have tricuspid. The remaining has either a 4 or 5 different leaflets, and that falls into the remaining majority of those patients. This is the prevalence of tricuspid valve regurgitation in general population. Most of these patients start to have more than 60 plus years, and the prevalence has gradually increases up as you go up on your age. And many of these patients are secondary to left side valvular heart disease, followed by pulmonary hypertension and LV dysfunction. This is an example of a patient who has primary tricuspid valve regurgitation. You can see a ruptured cord here. This is a patient who had pacemaker lead extracted, followed by a ruptured cord. And you see the central larger tricuspid valve regurgitation here with a vena contracta of almost 1.3. As an example of a secondary tricuspid valve regurgitation from an annular enlargement and a large cooperation zone in the center, where you see a very free flow of torrential tricuspid valve regurgitation. Almost 90%, as we have seen before, are secondary to the left-sided or pulmonary hypertension. The primary is very rare. In the past, we used to have rheumatic heart disease, or you have a myxomatous or an abstinence NMLA, or from iatrogenic, mainly secondary to lead extraction or RV biopsy, or patients who have pathological tricuspid valve regurgitation are mainly associated with annular dilatation and RV remodeling. This is just another schematic example to show like how on the top you see you have an elliptical annular shape. As you progress to the secondary tricuspid valve regurgitation and annular enlargement, the progression of the enlargement only happens in the anterior and the posterior surface, and not much on the septal to cause an oval shape of the tricuspid valve in the end. This is a very excellent schematic diagram to show at different levels of tricuspid valve insufficiency how you approach this. Especially here, when you have a tricuspid valve regurgitation, isolated and severe, you try to see if its conservative management is appropriate with no associated heart failure or symptoms. However, if you're going for a right heart, left heart surgeries, you would suggest to replace the valve. However, when you have an RV dysfunction, that itself can justify someone to go for tricuspid valve repair replacement if it is amenable and if it is feasible. And again, finally, the third stage, where you have a significant RV remodeling, RV enlargement, pulmonary hypertension, so on and so forth, the patient is surgically a suitable candidate, should go for a surgical valve replacement repair or consider for a percutaneous therapy. These are different therapies which are available. Many of them out of these are in the research world. They are like innovating more and more. Some fell apart and some are still going on in phase 1, 2, 3 trials. It's a very nice illustration here if you see mainly looking at the tricuspid annulus, where you have either a suture devices or an annuloplasty rings or a percutaneous cooptation devices which will reduce the co-opt zones, or a caval system where you have the valves deployed right near the superior and inferior vena cava to avoid having a vascular, an organ congestion. And finally, we have the valve itself to replace the tricuspid valve percutaneously. So this is just an example of one of our patients who we have done a mitral clip. When we fix the mitral valve, as you can see here with the mitral clip, on our way back we tried to do the same with the tricuspid valve, and this is where you can see how we are like aligning to. And this mitral clip has further modified itself, and then the Abbott company has made a TriClip, which is dedicated for the tricuspid valve, and they have released a 1-year outcomes which has shown a significant reduction, almost 84%, 87% reduction in the tricuspid valve insufficiency to only moderate, and there is significant KCCQ improvement and NYHA class improvement. And they have concluded that the patients who have the triluminary trial for 1-year follow-up has severe reduction in the tricuspid valve insufficiency and improved quality of life and heart failure symptoms. This is one of our patients. We are part of the CLASP pre-R trial, and this is one of our patients. The way we evaluated this patient, you see, it's by a multiplanar reconstruction to know what exactly is happening in the anatomical co-opt zone and where exactly we are planning to place the device. And this is once we get a multiplane reconstruction, we put the color right there, and we know whether we are going to grasp the septal anterior or the septal posterior. And we once we are ready to go, we advance the device, and we align right at the co-op, right at the zone we want, and we go transgastric views where we clearly see the septal and the anterior leaflets, and we grasp those leaflets very well. And once we are confirmed that the leaflets are grasped, we're going to like close the device and then check if the device is stable, grasping both the leaflets, and release the device to see how much residual leak is present. The 1-year follow-up data has been published last year, and it has shown again a significant reduction, almost like 80 plus 1-year reduction of mitral valve regurgitation to mild or moderate, and also almost 90% reduction of the NYHA function class, and also there is a significant improvement in KCCQ analysis with more than like 18 points, and almost like the reduction of the further functional 6-minute walk test to close to like 90 meters on an average improvement in the 6-minute walk test. This is another example to show like patients who have adverse sapien valve which is degenerated, which we thought of like putting a sapien valve in the ring, which is straightforward because we don't have to worry about the RVOT or obstructions or anything of any kind, and we got a very excellent result on this particular high-risk patient without surgical intervention. This is again a best example to show how important pre-imaging of these multiple new devices, whether you use FORMA or TriSynch or any of the cable devices, you need to have an extensive CT evaluation before we proceed with the surgery. This is an annular suture annuloplasty device where you have pledgets at the junction of the anteroposterior and the posterior, and you cinch it to reduce the annular space. And this is just a 3D demonstration to see how significant a reduction of the annular space has happened. And similar is an example of patient who is having a core-cinch device. Once you deploy all the anchors, once you cinch it, you know how much of the diameter has been reduced. Here in B, you can see a millipede device, which is again deployed in the mitral and the tricuspid area. Again, these are all in the trial system. Many of them are going on to the next phases. And here you see this is the device which goes externally to the heart and through the right atrial appendage, which kind of cinches the annulus from the pericardium. And on our way out, you close it with the nitinol closure device. Again, an example of how you tackle the heterotropic claval valve implant. You have to measure the distance from the right atrium IVC junction to the first hepatic vein. So you're not like closing the hepatic vein while you're deploying it. So it's still perfused while the valve stays above the caval system, where you see right here the valve is above the IVC and the RA junction, and you still perfuse the IVC without any issues. This is a trick valve, and you use the trick valves to deploy it in the SVC, IVC, and the sapien valves in a similar fashion. These are the orthotropic transcatheter tricuspid valve. This is a Navigap, and you have the fluoro of how the Navigate looks like once it's deployed here. This is a 42 French deployed either through IVC or through direct mini thoracotomy, and this is the Lux valve. All of these valves are very promising, all in the 2-3 phases of trials, and we are still waiting for appropriate results. This is the initial most the Navigate trial, not just the deployment in the pig where you're going directly deploying it. Now almost 30+ patients are being used as a compassionate use with a significant reduction in the TR, and we're still waiting for the final results of this trial as well. This is an Evoke system, the Trisent study, which is a valve itself, which you can see there is a good anchoring support to the valve itself. It anchors the valve, and you have a bovine pericardium within the device to function as a normal valve. This is the 1-year trial outcomes, which has shown almost 95% reduction in the TR severity, almost 93% reduction in the NYHA functional class, and it has shown 9% mortality and 10% heart failure hospitalization, and there is significant quality of life improvement with more than 25 points, and also a significant 6-minute walk distance on an average. And these kind of trials are really promising for us to know that there's future for these devices and future for people who are very high risk for this very complex anatomical valve. Now, in summary, the tricuspid apparatus is very complex and more complex than mitral valve. I think in the secondary TR is 90%, usually related to the left heart failure or pulmonary hypertension. Medical management leads to higher mortality compared to patients with trivial or mild TR. High mortality for isolated TR surgery is almost 9%, and it increases the 30% if you do a redo surgery. Edge-to-edge technique is promising, and multiple transcatheter devices are under clinical trial and waiting for final larger trials to start using on a day-to-day clinical basis. Thank you so much, and we're happy to have questions.